Here we have a 45-year-old woman presenting to the emergency department with gum bleeding, joint pain, and fatigue. Her symptoms gradually worsened over the past 3 months. She has limited diet, considering most of tea and toast. Tea and toast. Impaired synthesis of what? All right, so this is a pretty easy question. Tea and toast. This is going to make you think of she has limited diet, gum bleeding, vitamin C deficiency, scurvy. It's essential for the hydroxylation of proline and lysine. Hydroxylation of proline and lysine is the really buzzy thing to say. Also, this low serum ascorbic acid is also very confirming of vitamin C, because vitamin C is a sorbate. And if you don't have this, then you don't have hydroxylation. And without that, the collagen fibers can't actually form stable triple helices. And if they can't form stable triple helices, then you have weak connective tissue, you get bleeding gums, easy bruising, all that stuff. So scurvy. I feel a scurvy coming on. All right, so vitamin C deficiency leads to impaired collagen synthesis, causing symptoms like gum bleeding and petechia. All right, we'll just keep improving. Keep on going. That's what we do here. So a 28-year-old woman visits her gynecologist with concerns about irregular periods and difficulty becoming pregnant after trying to conceive for 2 years. Her menstrual cycles vary between 30 to 45 days. She reports occasional mild hirsutism. A pelvic ultrasound reveals multiple small follicles in the ovaries consistent with PCOS. Her physician prescribes clomiphene citrate. Which of the following changes in hormone levels is most likely associated with the administration of clomiphene citrate?
My periods are all over the place, sometimes every 30 days, sometimes 45. We've been trying for 2 years now and nothing. I've even noticed a little more hair on my face.
Okay, it's going to be the increase of the serum gonadotropin levels. So this is a SERM. It blocks serotonin receptors in the hypothalamus, and you have basically, it's like a fertility drug. The goal is to remove the negative estrogen feedback, leading to increased FSH and LH from the anterior pituitary. So clomiphene increases ovulation by blocking estrogen receptors, and it disinhibits the secretion, boosting FSH and LH. So you're going to boost those levels ultimately. All right, so in PCOS, you have chronic anovulation due to the disrupted LH and FSH balance and also the constant estrogen exposure without progesterone cycling. And that leads to a negative feedback suppression of GnRH. And also clomiphene is going to act like a fake low estrogen signal. And so you remove that feedback and then bad things are going to happen. So clomiphene blocks the estrogen's negative feedback. Basically, clomiphene is like a fake low estrogen signal. And so it allows the GnRH pulses to resume. And then you get to increase FSH and LH, and that promotes follicular growth and also ovulation. So let's see if the bottom line is working. Clomiphene citrate increases serum gonadotropin levels by blocking estrogen receptors, stimulating ovarian function. All right, so we feel like about clomiphene and polycystic ovarian syndrome. Basically, we're giving them a fake receptor so we can stimulate the GnRH so we can have more follicle growth. We're stimulating the nexus so we can have more FSH and more LH. That's the job of clomiphene citrate. Also, whenever you're prescribing clomiphene, watch out because there's like clomiphene, clomifid. There's some other drug that looks just like clomiphene. And if you don't spell it right, then they're going to get some other drug which does like headache stuff instead of stimulating their gonadotropin releasing hormone. So just be on the lookout for that if you guys are hoping to be endocrinologists. All right, moving on. Okay, a geneticist is researching the prevalence of a particular autosomal recessive disorder that provides a protective effect against the widespread infectious disease in regions Southeast Asia. Geneticist notes the allele frequency of this disorder among Southeast Asian populations is higher than others. What explains for this? All right, well, here they mentioned that it's an autosomal recessive disorder, which is actually super important for this question. And so if it's autosomal recessive, then it's going to be passed silently through carriers. And so this is going to require both alleles for expression. And so this is protective against some other disease. This is really hinting at heterozygous fitness. The same reason that sickle cell allele is very common in African populations because it's heterozygous, conveys some fitness onto the host. Also, there's a higher prevalence in Southeast Asia. So there's like selective pressure from, let's say, like malaria or some disorders that protect against Plasmodium falciparum infections. And so the geographic distribution is going to be natural selection, not random drift necessarily. So the answer is B for this question. Here's the bottom line. Natural selection explains higher allele frequency in an autosomal recessive disorder in Southeast Asia due to protective effects against the infectious diseases. All right, you guys can see the symptoms of the eye patient, and seeing this will be working.
So you're feeling more tired than usual. The blood work shows the anemia we talked about. It's linked to a genetic condition common in this part of Asia, which, oddly enough, also gives some protection against malaria.
All right, 14-year-old boy is brought to the clinic by his mother because he's noticed a small, tender lump under his right nipple for the past 2 months. He has no other symptoms and is otherwise healthy. He reports no use of medication or supplements. On physical examination, his height is at the 75th percentile. His weight is at the 70th percentile. Tanner stage is 3 for pubic hair and 3 for genital development. Examination reveals a palpable 2 centimeter firm mobile subareolar mass of the right areola. Left breast is unremarkable. No. Yep, you got it right. Indeed, it is physiologic gynecomastia. So he's got the tender lump. That's classic for the location of gynecomastia. Tanner stage 3. We have a mild kind of transient estrogen testosterone imbalance. No medication or supplement use, so it's not going to be drug induced. And also, it's going to be a firm, mild subareolar mass. Fibroadenomas, well circumscribed rubbery mass. Rare in males due to the lack of lobular tissue, typical in young women. Epidermal inclusion cysts. It's not going to have the hormonal features. Lipomas are soft, painless, mobile masses. Intraductal papilloma has the bloody nipple discharge, unlikely in males. So puberty, there's just all sorts of weird imbalances between estrogen and testosterone. And that can cause some glandular breast tissue in boys. It's called pubertal gynecomastia. So firm, mobile, subareolar mass in a pubescent boy most likely indicates physiologic gynecomastia. All right, well, we have a 34-year-old man, a history of recurrent depressive episodes, is participating in a clinical study investigating cellular metabolism under stress conditions. As part of the study, his muscle cells are biopsied and subjected to nutrient deprivation in vitro to stimulate conditions of cellular stress. The researchers aim to examine the process by which these cells recycle into intracellular components, which the following indicates autophagy has occurred.
They took a small sample from my thigh earlier. It's part of the study, trying to see how my muscle cells handle stress when they're low on nutrients. I just sit tight while they run their tests.
Tricky question. So basically autophagy, whenever your cells are starving, they, instead of just sitting down and dying, they actually eat themselves. And that's called autophagy. And that's when cells are trying to recycle their proteins and their organelles, and they're trying to use them for energy. And so the hallmark of this is going to be the autophagosomes. They're double membraned vesicles that capture the old cellular parts and they fuse with the lysosomes to digest them. And there's a key marker that you have to know about autophagy, and that's the LC32. It's a protein that moves from the cytosol onto the surface of the vesicles. And so you're also going to see some other things, but a lot of these other answers are pointing toward things like apoptosis, for instance, DNA fragmentation, and also AIF release, that's apoptosis. But here is the LC32 on the autophagolysosome membrane, means that the cell is literally just eating itself. So that's the autophagy. All right, so the answer is going to be B. It's the movement to the autophagosomal membranes by your LC32. Nutrient deprivation in vitro is a key stretcher for autophagy. Translocation to autophagosomal membranes is the gold standard for autophagy. So just kind of recognizing that it's different than apoptosis. The caspase 8 in apoptosis is associated with TNFR1 activation, P53, damage and stress response. So there you go. So movement of LC32 to the autophagosomal membranes indicates active autophagy in muscle cells under stress. All right, so here a 50-year-old woman with a history of kidney transplant 2 years ago presents to the clinic with a 3-month history of persistent fatigue and progressive neck swelling. She has been on immunosuppressive therapy, including tacrolimus and mycophenolate, since her transplant. Her temperature is 100 and her pulse is 88.
I've just been so tired the last few months, and the swelling in my neck hasn't gone away. It started small, but it's been getting bigger.
Respirations are 14 and the blood pressure is 119. Physical examination reveals palpable cervical lymphadenopathy. A lymph node biopsy is performed, and immunohistochemical analysis shows Epstein-Barr virus proteins within the cells. Which of the following mechanisms is most likely responsible for the development of this patient's condition? Dom says E, and Dom is indeed right. Yep. So what's happening here is that drugs like tacrolimus and mycophenolate, they keep the immune system quiet by blocking the T cell activation. And so that's going to be good for the graft, but it's bad for a lot of other things, like, for instance, viral control. And so when your cytotoxic T cells are suppressed, Epstein-Barr virus infected B cells are going to start growing unchecked, and that leads to post-transplant lymphoproliferative disorder. And that's a type of Epstein-Barr virus-driven B-cell lymphoma, similar to the very first question that we did. Nice. Welcome back. So the patient's lymphadenopathy and Epstein-Barr virus positive biopsy is the result of the inhibition of the cytotoxic T-cell activity. It's the inhibition of the cytotoxic T cell activity, and that lets those infected B cells start to multiply very freely. All right, here are the attending tips. Kidney transplant 2 years ago. High risk. The patient is high risk for some post-transplant complications. And on immunosuppressive therapy, the immunosuppression limits the T cell surveillance, and the Epstein-Barr virus proteins implicates the Epstein-Barr virus-driven lymphoproliferative diseases. So watch out for that post-transplant. Mycophenolate and also tacrolimus are T cell suppressors. So there are a lot of, it's like 10% of the post-transplant lymphomas are caused by Epstein-Barr virus because Epstein-Barr loves the B cells. It loves to infect them and proliferate them. And normally the cytotoxic T cells keeps the B cells in check. But if you give them these tacrolimus and mycophenolate, the cytotoxic T cells can't do their job, so the B cells proliferate. And they're all up in your business. And that's the truth. That's the truth, man. So the bottom line is post-transplant lymphoproliferative disorders due to malignant transformation of B lymphocytes from Epstein-Barr virus in immunocompromised patients. Okay, so the patient over here is saying her chief complaint, and Dom says, so does the patient have a lymphoma now? I guess which kind? Yeah, so the patient does have a B-cell lymphoma. It's a post-transplant lymphoproliferative disorder is what she's got. So if this is unchecked, this is going to behave just like a diffuse large B-cell lymphoma. And if you catch it really early, then it can regress with some reduced immunosuppression. So that's a good question. But essentially, this is acting like a diffuse large B-cell lymphoma. So there's an argument, I guess, for mycophenolate and tacrolimus causing diffuse large B-cell lymphoma, if you put it like that. Here's our bottom line. Here's the AI patient. Here's us moving on. Yeah, anytime, Dom. I love that question. That was a really good question. Makes you think. All right, here's the next question. A 2-year-old boy is brought to the emergency department by his mother due to fever and lethargy. He recently had a viral upper respiratory infection. His temperature is 103.1. Heart rate is 130 per minute. And respiratory rate is 28 per minute. Upon physical examination, he appears irritable and has increased work breathing with intercostal retractions. Lung auscultation reveals coarse crackles bilaterally. Lab shows white blood cell count of 52, that's high, and also 70% segmented neutrophils, 15 band, and less than 5% are myeloblasts and promyelocytes. Which of the following best explains the mechanism behind the elevated leukocyte count in this patient? Okay, so it seems like we got some huge infection here, and the bone marrow is damaged, and it's causing some problems. So cytokines, for instance, IL-1 and TNF-alpha, they tell the marrow to dump the neutrophils into circulation. That's what the cytokines do. They're like, hey, get in there. And that includes the immature band formation. So there's a surge of white cells, and this is like above 50,000, which is a ton, more than 4 times what you normally have. It looks like leukemia, but in this case, it's actually not cancer. This is a leukemoid reaction. So this is a process where the bone marrow is working overtime to fight that infection. So the child has a high white blood cell count with mainly mature neutrophils and bands, and that's due to the enhanced release of stored neutrophils from the bone marrow. So it's not necessarily a malignancy. So the answer is going to be C. It's enhanced release of mature and immature neutrophils from the bone marrow stores. They have the recent upper respiratory infection, followed by fever and respiratory distress, white blood cell count of 50,000, and 70% neutrophils, 50% bands, leukemoid reaction. Malignant would have the blast greater than 20%. No blast crisis there. Less than 5% of them are immature. Decreased apoptosis, prolonged survival. That's not the mechanism in acute infections. It's not survival. They're proliferating. Proliferation in lymphoid tissue. Well, that's not neutrophils. These neutrophils mature in the bone marrow, not the lymphoid. Synthesis in the liver. That's acute phase reactants like CRP. Liver does not produce the neutrophils. It's the bone marrow's job. All right. There's a left shift. The band formation. Toxic granulation, dual bodies, and cytoplastic vacuoles are seen in neutrophils during infection. Less than 5% myeloblast confirms that it's a reactive process, not leukemia. Okay, so GCSF and IL-1 stimulates early release of the marrow reserve neutrophils. There's the pathophysiology. They're the key features. So even if you have a white blood cell count that's greater than 50,000, it does not always mean that it's cancer. Does not mean that it's cancer. So the bottom line is elevated leukocyte count in this child is due to the enhanced release of mature and immature neutrophils from the bone marrow stores. All right, so this question is just asking which of the following mechanisms most likely accounts for the methicillin resistance of this strain if we know that it's MRSA. So we need methicillin resistant Staphylococcus aureus, that's MRSA. We have to know this mechanism. All right, so let's talk about how Staph aureus becomes the world's biggest hospital nightmare. Methicillin is usually going to kill bacteria by binding PBP, and it blocks the cell wall cross-linking. But MRSA has picked up the MEK-A gene, and that makes a new version of PBP called PBP2A, and that is a version that beta-lactams cannot stick to. And so even though you have the antibiotics, that bacteria keeps building their cell walls just like nothing happened. And that's why MRSA is resistant to all beta-lactams, and that's why we have to turn to vancomycin or linezolid instead. So here's the resistance that's coming from the altered target binding site. So our answer is C. So methicillin-resistant Staphylococcus aureus, MRSA, the clue is going to be the alteration of the penicillin binding proteins as the resistance mechanism. So synovial fluid analysis shows high white blood cell counts and predominance of neutrophils. So the knee is red and warm and tender to touch with fever. It's mono, articular septic arthritis. MRSA specifically resists beta-lactam antibiotics, not by degrading the drug, but by changing the drug target. Methicillin resistance. There we go. All right. What about the biofilms on the prosthetic surfaces? So that's going to be actually common in a different organism. That's S. epidermidis. And those are when you have the prosthetic devices, and it's not going to be the mechanism of MRSA, though. What about these extended spectrum beta-lactamases? So the ESBLs. Well, those are found in E. coli and Klebsiella. They hydrolyze the penicillins and the cephalosporins, but not the carbapenems. Overproduction of the efflux pumps. So the overproduction, that's the mechanism for tetracycline and macrolide resistance, not beta-lactams. Decreased permeability of the cell membrane. So that's going to be common in gram-negative bacteria or Pseudomonas, not gram-positive Staph aureus. Yeah, Pseudomonas or Enterobacter. So MRSA doesn't fight methicillin by destroying it. It just makes it useless. It changes the target. Pretty wild stuff. So MRSA resistance is primarily due to the alteration of the target binding site, specifically the penicillin binding proteins. Okay, and look at this. We actually have our patient here. This is exciting. So let's watch this AI simulation. Okay, here it is.
It hurts so much. It's really hot and swollen. I can hardly move it.
Okay, there's the presentation of the 34-year-old woman with her pain and swelling of her left knee. We found out she had MRSA, and there has been some transformation, the alteration of the target binding site in this patient. Okay, so here we have a 45-year-old woman presenting to the clinic for a routine checkup. She also has a history of poorly controlled type 2 diabetes mellitus, and chronic hypertension, for which she's on multiple medications. During the consultation, the physician notices that the blood pressure is 160/95. When asked about her medication compliance, she says, "I take the pills whenever I remember, but I feel fine most of the time, so I'm not too worried." They seem unconcerned about her condition despite elevated readings and downplays the importance of taking medication regularly. Which of the following is the most appropriate response by the physician? Bromdeep says C. Discuss the health risks of untreated hypertension and diabetes and ask her to consider. Yep, the principle here is we got to educate them, right? So the answer is indeed C. I take pills when I remember, but I feel fine most of the time. So there's lack of insight or understanding to the asymptomatic nature of the chronic disease. BP is at 160/95. HbA1c is at 9.5. Both values reflect uncontrolled chronic disease with increased risks of complications. They're downplaying the importance. Hypertension and diabetes are often asymptomatic until the complications arise. Nice job, Iqbal. You got it right as well. Okay, here's the bottom line. Discussing health risks and tracking medication intake is crucial for managing poorly controlled diabetes and hypertension. And also, you got to educate in a lot of these ethics questions. Yes, it worked. Check this out, guys. Ready? Yes. Okay, we can watch this together now. So here we go. 3, 2, 1.
I take the pills whenever I remember, but honestly, I feel fine most of the time, so I'm not too worried about it. It's hard to keep up with all of them, you know?
That is so cool. There's our patient, guys. She came to life. Look at it. She's a 40. Sorry, I keep running out of RAM on my computer. So there it is. A 45-year-old woman presents to the clinic in a routine checkup. She has poorly controlled type 2 diabetes and chronic hypertension, for which she's taking multiple medications. During the consultation, the physician notices that the blood pressure is at 160/90. By the way, I just made some changes to the code, so that should also reflect there as well. The patient monitor that I've also made from scratch. But here we go. The patient is unconcerned about her condition despite her elevated reading and downplays the importance of taking medication regularly. What's the best response? As you guys noticed, as you guys all noted, the answer is C here. Discuss the potential risk of hypertension. And then here is the bottom line. So discussing the health risks of things like chronic conditions like hypertension and diabetes is important because educating is part of the role of the physician. And then we go here, and now we can see our patients. And so then I just click this.
I take the pills whenever I remember, but honestly, I feel fine most of the time, so I'm not too worried about it. It's hard to keep up with all of them, you know?
Okay, so what is your response? You should discuss the potential health risks of untreated hypertension and diabetes and ask her to consider tracking her medication intake. Should you schedule a follow-up in 6 months? No, right? She doesn't understand this chronic condition is going to actually need some education, and we also need to address that hypertension and the diabetes. So what about advising to double the medication and return in a week? Why is that one wrong? Well, the double medication dose. That's wrong because adjusting medications without adjusting the root cause of non-adherence, which is the patient's behavior, is dangerous and unproductive. What about referring to a diabetes? Well, education class, that's passive referral without direct engagement. Okay, so the principle here is you have to engage and you have to educate. And so that wraps up our question 60.
Like and subscribe if you dig the vibe.
Smash that like button.